how you would do the S part. And then what I think I'm going to have you guys do instead of that video is I'm just going to give you guys like 5 little case things where you would just write up an S part for it. Okay, and they're quick, simple, and you'll turn that in instead. Okay, so that way all you people that are afraid of cameras. However, once you do that, we do have a day coming up where then you're going to be expected, I'm going to call people at random for like the 5 or 6 cases, whatever I post, to come up and do their S part in front of the class, like present it to the class, the case. Okay, because one of the skills that you guys, we repeatedly hear is lacking from our students when they get on rotation is presentation skills and ability to stand up in front of a group and speak. Trust me, it's something I work on every day. I'm very nervous standing up here and speaking in front of you guys every single time I'm up here, if you can't tell. I have to bring extra changes of underclothing just to change after class because it's so nerve-wracking. Okay, so we're going to talk about this communication. And SBAR is basically in medicine the way, a methodology that we've adopted to communicate with each other in a quick and efficient manner. As you can see, these 3 guys in the OR did not communicate in a quick and efficient manner. It says, and that's why we count on 3. You can see the guy at the head of the table, or the foot of the table, still holding the patient's feet. Okay, so, and I've actually seen this happen many times when we drop patients, but bad communication. Okay, so, this is what SBAR stands for. It stands for situation, background, assessment, and recommendation. I'm sorry? No. Get out a pen and pencil and write it down. Listen, this is the only informational slide of the whole presentation. Okay? Other than that, we're just going to practice. So, if you can't write down 4 words, then I know you guys are drained from your exam. It was a lot, I understand. Okay, so situation, the S and the B kind of go together here, okay? So situation and background, I always say, the situation and background, I'm like, the situation and the background are kind of the same thing. If I'm describing the situation, there's the background behind the situation. So the S and B kind of go together to me. So situation says, briefly describe the situation, give a succinct overview. The key word in all these is going to be succinct. Okay? If you Google SBAR, you'll find 1,000 of these things. It's not like it's, some proprietary or whatever. Background. Briefly state pertinent history, what got us to where we're at now. Okay? So this is kind of like the HPI, right? Assessment. Yes. Question? Okay. Assessment. Summarize the facts. What do you think is going on here? So this is where you're assessing the situation. And then what are you asking for? This methodology of communication is great for everything. If you're standing in a Publix filling a prescription and it comes up with a problem, you should have this thought process running through your head. Because when you call the doctor, this is exactly what you should be doing. Okay? Mr. Heerholzer came in for a refill of his Percocet. There is no refills on C2 medication, so I would just like to know if I can send him to your office now, because he's stating he's still in pain and blah, blah, blah. I'd like to know if I can send him to your office now. Right? It's just a quick, the situation, the background, he was prescribing for his knee surgery, whatever. I think he still needs it. He looks like he's in pain, but I can't make that judgment. I would like to recommend that he comes and sees you. Are you available now for him to come see you? Right? Something like that. Okay. Everybody understand this SBA? Oh my God, I'm impressed. I'd have been out drinking by now. I got to be honest with you. We're not being recorded, so I can say that. After an exam, let's see, that exam started at 9. I'd have been done by like 9:18 and been across the street. Not because I was smart, I just bubbled in any answer. Okay, so situation, background, assessment, and recommendation. Okay? Actually, I'm just flattered that you're all here. That's it. You must have a class at noon or 1. I love you all. Until next year, when I don't get to teach you or anything anymore, then you'll all forget about me, and I'll forget about you. But I won't forget about you. Okay, so everybody got this in their head? Now this should look familiar to you. Jason Jones is a 7-month-old Caucasian. He's a 7-month-old boy who presents with symptoms of an ear infection. Patient's mother, Stacy's been tugging on his ears over the last day or so. He also has a fever, which started around the same time, went up to 104, which is taken rectally. Mother denies any altered mental status associated with the fever. He's fussy, crying, which is inconsolable. He's also not sleeping well, denies increased sedation or lethargy. Patient attends daycare, blah, 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 blah. So everybody kind of read over that, and then we're going to go ahead and come up with an S part for this patient, right? You're all familiar with this patient? If you're not, you better not have gotten any points in Latin. Okay, so Palm Beach, I would like you to, after reading this, I'll give you another minute, one of you brave souls to push your microphone button and give me the SB part of this, right? The situation and background. Remember, quick, succinct, okay? Just what you need to know. So basically the situation here is, you guys all talk to this mother. We're going to assume the objective data came back saying it's okay, it's an ear infection, okay, since we didn't get objective data. I want you now, you're going to now communicate to the doctor. You're looking to go ahead and make a recommendation, okay? So situation, background, then we'll have somebody else do the assessment and somebody else do the recommendation, okay? So Palm Beach, give me the situation and background.
Seven-month-old infant with a pos.
Can you hear us, Professor?
I heard 7-month-old infant with a pos, and then it stopped. Yes, I can hear you.
Possible ear infection.
Okay, but we're assuming now that this is at the end of everything. You've gotten objective data back, you've gotten everything. It's an ear infection. So now tell me about it.
It probably hurts the child.
I'm sorry?
It's causing most of the child's symptoms, such as the fever, the tugging on the ears, the insoluble crying. Do you mean what medication we would recommend?
No, I just want the the situation and background portion. So I would say, here, let me help you out. We have a 7-month-old boy with symptoms of an ear infection. He's had a fever, trouble sleeping, diarrhea, and increased urination. There's no other pertinent signs or symptoms. Mother has used ibuprofen with relief for the fever. See how quick, simple that is summing up? I don't need every piece of information that says it's an ear infection. I don't need every little bit of information, right? I'm just trying to orient the physician to who it is I'm talking about, okay? The physician, and you should build this kind of rapport with people, but the physician should assume that you understand what you're talking about. So when I say it's a 7-month-old boy with signs and symptoms of an ear infection, I don't need to say tugging at the ear, inconsolable crying. I'm a healthcare provider. I know what signs and symptoms of an ear infection are. He's a healthcare provider. He understands, or she understands, what signs and symptoms of an ear infection are. So therefore, I don't have to spell out all the different signs and symptoms. I will mention there's a fever because that's pertinent, right? So 7-month-old boy, I'm giving him, it's a boy, he's 7 months old, it's an infant, right? So that's my patient. He's got an ear infection. He's had a fever. He's had a couple other signs and symptoms, trouble sleeping. I'm mentioning the diarrhea and increased urination because then when I make my recommendation for treatment, that's in his head too, in case what I make a recommendation for would not necessarily be good in case the kid's dehydrated or something. It's just giving him a little more information about other possible things that could be going on with him. And he has had some ibuprofen for the, so if he wants to give something for the fever, he now knows that the mom's used ibuprofen, she has ibuprofen at home, and it's worked. Right? Does that make sense? See how I kind of combine situation and background? Because I've never quite understood how to separate them out. To me, it's kind of one thing. Right? Okay. So now we get to our, what? SBA is our assessment. So, that's the background. I'm not saying you necessarily had an ear infection yet, because it's just the background, right? Now my assessment is going to be what I think is going on with the kid, right? So, based on the signs and symptoms, I believe the patient is suffering from otitis media with a lack of external symptoms. We didn't have any objective information for this case, but this is where I might say that, you know, a chest x-ray showed this, or this, you know, if it's relevant to it, right? Okay, so that's where your assessment is going to be, this is what I think is going on and why. But quick and succinct, not a big long thing. It's a little 5-sentence, this is what I think is going on. This whole presentation to another healthcare provider should be 30 seconds to a minute, at the most. Okay? So now, I think it's otitis media, there's no external component, because we've looked at his ears, whatever else, there's nothing going on there. So I believe it's that, and as such, since I believe that that's what it is, I recommend we give the child amoxicillin 400 milligrams by mouth every 12 hours for 10 days. We'll reassess him in 3 days for symptom relief. If there's no relief, I recommend changing to augmentin 400 by mouth every 12 hours. That's what I want to do. Did everybody follow along there? San Juan, does that make sense to you guys? What we just did? Hello, San Juan.
Yes.
Good. Can anybody tell me what the dose of amoxicillin is for a pediatric patient? 80 to 90 milligrams per kilogram. Does anybody know what the dose of augmentin is for a child? An infant under 2? 80 to 90 milligrams. How did I come up with 400? 80 is like 360 or 380, and the 90 is 525 or 425, so 400 sounds good to me. It's in the middle, right? I'm sorry? No, he's 7 months old. We're going to probably give him the suspension, not a tablet. The question was, would we give him a tablet? No. It does come in a... What? I'm sorry, you don't take a suspension by mouth? What do you take a suspension in your ear? Suspensions do have milligrams. Suspensions have concentrations, right? So it's X milligrams per milliliter. That's good. You just came up with a good question for all of us. Thank you. So ready? Get a pen and paper out. So we want to do this for this child. Okay, so 400 milligrams twice a day for 10 days, right? It comes in... Hold on. It comes in... It comes in 250 milligram per milliliter, 10 milliliter bottles. 250 per milliliter. I'm sorry, 250 per 10 ml. No. 250 per ml, 10 ml bottles. How many mLs would the patient have to take, and how many bottles would you have to dispense? Oh, it's 250 per ml, 10 ml bottles when it's reconstituted. Thanks for creating work for everybody. That was awesome of you. I appreciate it. Doesn't matter what he weighs. You have a dose that you need. But he weighs like 21.3 pounds. So, how are we going to figure this out? Because this is something that comes up all the time in retail. So, 250 per ml, 10 ml bottle. So how much is in a bottle? 2,500 milligrams. How many milligrams does he need a day? 800. So one 2,500 milligram bottle will last him 3 days. Right? So basically he needs how many bottles? 4 bottles. Huh? No, we would give him the whole supply. It's not like we're going to give him a 3-day supply, and then if he's doing okay and getting better, we give him more. No, when they write the prescription, they write it for 10 days. You just want to make sure it's working, because if not, we need to switch to something else. Right? Everybody see how you do that math? Dr. Finkel would be proud. Okay, so let's try again. This should look familiar to you. This is Miss Rena Cross. She should look very familiar to you. You just saw her less than a week ago, right? And you all chatted with her, right, Palm Beach? You chatted with Miss Rena Cross in your lab? In your clinic? Yes. Perfect. Can you guys read this slide? No. Look closer. So, you should all remember. You shouldn't have to read the slide, right? You should all remember this. So, here you go. Here's the HPI. Presented to the primary care physician complaining of pain in the right leg. She states she awoke with the pain 3 days ago and has been continuous, although it hurts more when she walks. pain is located behind her right knee and extends down into her calf. She rates the pain as a 3 of 10 at this time. She denies chest pain and shortness of breath. She denies recent travel or leg injury. Patient recently started rosuvastatin for treatment of dyslipidemia. I would have put recently, it was a year ago. Approximately 1 year ago. She stopped rosuvastatin 3 days ago because she thought it could be the cause of the pain, but the pain has persisted. Okay, so auditorium B. Since now there's a group of you in there, even though there's actually filled up pretty nicely. Auditorium B. Give me the situation and background for this patient, please. Give me a situation and background. You guys should all be familiar with this patient. It was just last week, with the exception of one of you. Where is he? Oh, he's not here. Maybe he's in auditorium B. I'm not afraid to call people out. Auditorium B, neighbors. Come on, give me a situation and background. They're a little slow on the draw. You guys are all tired from being up all night studying? I love seeing everybody here in Fort Lauderdale sitting out front of the auditorium with a minute to go, cramming stuff into their head. Did you ever see that episode of Married with Children where he tries to cram too much into Kelly's head and stuff starts coming out the other ear? All right, San Juan, help me out. Give me an S and a B for this patient. Here's the beauty, guys. There is no right, wrong answer here. It's just how you're going to do it. Is this thing on?
Immobility?
I'm sorry. Go ahead, San Juan. Start from the beginning. Give us an S situation and background for this patient.
It's difficult to read.
But you guys,
We're having a hard time.
you remember the patient, right?
Like,
I'll give you some slack on like the age and whatever, but you remember the patient, right? I hope. It was 6 days ago. 7 days ago. Oh my goodness. Okay, somebody here that can read, go ahead.
Cross has presented with leg pain that is continuous, and I guess we can say that sonography has found.
Yeah, it's not background stuff, that's assessment, right?
So it's continuous, no relief, patient has not taken anything.
Okay, so she said Rena Cross.
It started in the morning.
Rena Cross is here with consistent leg pain that started in the morning.
Continuous.
It's continuous
No relief.
with no relief. Okay. Do we care what her name is? No. We're talking to the doctor. I mean, they might say which patient, so their name might be appropriate it depends on the situation. Okay? Anybody else want to take a stab?
43-year-old presented with signs and symptoms of DVT, leg swelling and pain for 3 days. She hasn't taken anything. She just stopped taking the pressure medication and is currently using the Novocaine for 7 years.
Okay. Not bad. Smoker. Anything else you guys think we should include? Let's see. This was what I said. 43-year-old female with 3 days of 3 out of 10 constant posterior right leg pain from knee through the calf with no trauma or recent travel. Patient on rosuvastatin for dyslipidemia, which she self-discontinued 3 days ago, but pain has persisted. Right calf warm to the touch and tender with mild edema. That's swelling in your blood. Edema. With mild edema. Okay, so that's just, here's the situation in the background of the patient, right? I could have done some more background. I could have said, which I'll get into later under my assessment, about smoking or estrogen or whatever. But basically, I'm just giving you the situation is, this lady looks like she has a DVT. Does that make sense? And it's been going on for this long. So now my assessment. What is our assessment of this lady? Now this is where we start bringing in that our objective information and stuff, because this is what I think is going on and why. Palm Beach, tell me, what do you think is going on with this patient and why? You should remember the patient.
She's having a DVT.
Correct, but now explain it to me like I'm the doctor. So, Dr. Hiraholzer, I believe this lady's having a DVT, and why? You remember the stuff from the case. Why?
She's got a warm calf, she's got tenderness, she's got pain that's consistent within the leg.
How about
There's
objective
no
information?
relief of symptoms.
Okay. Objective information? How about the lower right over here? We had an ultrasound, right? So we would be able to say, oops, I'm going backwards instead of forward. We'd be able to say, okay, so that was good, other than you need to add objective information in. Okay? So, patient has a confirmed acute DVT, blah, 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 via ultrasound. Patient currently is sedentary, overweight, taking estrogen for birth control. And I even forgot to mention that she smokes. Okay? But that's okay. If you don't list every single risk factor, you're still getting the point across. Okay? I didn't list smoking on purpose to show you. You don't have to, right? This is saying, look, there's an ultrasound that says it's a DVT. She has some risk factors. Here are some of the reasons, other reasons to support it's a DVT. She's got a DVT. Right? Does that make sense? So, going back, 43-year-old female. Let me just read it out for you right now. You ready? So, this is basically what I would say. Time me. It's a 43-year-old female with 3 days of 3 out of 10 consistent posterior right leg pain from the knee through the calf with no trauma or recent travel. She's on rosuvastatin for dyslipidemia, which she self-discontinued 3 days ago, but pain has persisted. The right calf is warm to the touch and tender with mild edema, not edema, edema. The patient has a confirmed acute DVT of the right distal superficial femoral, popliteal, and perineal veins via ultrasound. Patient currently sedentary, overweight, and taking estrogen for birth control. I recommend we begin the patient on rivaroxaban 15 milligrams by mouth twice daily for 21 days, then rivaroxaban 20 milligrams for a minimum of 3 months. I also recommend we discontinue the estrogen-containing birth control and suggest barrier methods until she can discuss alternatives with her OBGYN. I also recommend that we resume her rosuvastatin as previously prescribed. Okay, less than a minute. I got the point across of the situation, the background, what I am assessing is going on, and what I would like to do about it. Right? My recommendation. Does everybody see how that goes? Questions about it? Yes. Use your mic, please.
So in this recommendation, we're not including any of that education and plan of, like smoking or weight loss or...
You could. Okay, let me ask you this question. Who is going to initiate the smoking cessation? The doctor? Who's going to do that? You? So I'm basically saying, I want to treat her with this for her DVT. The other stuff, the lifestyle modifications, I mean, you could throw in here, I'm also going to try and initiate lifestyle modifications with the patient, such as smoking cessation, diet, exercise. Okay? But you're not asking for anything from the doctor for that. You could absolutely add that in here. That's not wrong. Like I said, there is no wrong or right here. It's what you want to do. Okay? It's quick, succinct. Me, I've been practicing long enough, this is what I'd say, and then I would talk to the patient about diet, exercise, smoking cessation, everything else. It's not bad to let the other healthcare providers know that stuff, but when I actually document the clinical note, then I'll document it. In my interaction with the physician, I want to be quick and succinct. Okay? And think about this. It's not just in like a case like this. It's anytime you're contacting another healthcare provider for anything, right? Think about if a med has no refills, or there's a drug interaction, and you're in a community setting, right? You want to basically say that, you know, Lena's been prescribed this medication, but she's all, you know, Lena, she's a 43-year-old with hypertension and diabetes, and you prescribed this medication for her diabetes. She also, however, for her hypertension, has this medication, and they have an interaction. As such, I would like to recommend that we change this medication to this, therefore there will be no interaction, and it's still covered, and she'll have no issues. Right? So you're just still doing that situation, background, your assessment of the problem, and then your recommendations. It applies to any communication, basically, if you think about it, right? It applies to if you're having a drug shortage in your hospital, right? Here's the situation. We use phenytoin for our seizure patients all the time. Unfortunately, phenytoin is on back order from the manufacturer. We're not expected to get it back in for another 6 months. As such, an alternative would be phosphenytoin, which is currently available. So we would like any phenytoin orders to be switched over to phosphenytoin in the equal milligram strengths, and therefore we will start using phosphenytoin to treat our patients with active seizures until phenytoin becomes available again. Right? So I've explained the situation in the background, my assessment of the problem, and what I recommend we do for it. Right? It applies to just about any communication you're gonna handle. Okay? So now you got SOAP and SBAR. I'll think of another S thing we can come up with for you. Palm Beach, do you have any questions on this form of communication? I put this together in 5 minutes before class because I totally switched streams on what we were doing as far as the video goes. So sorry it didn't take the whole class. San Juan, do you have any questions about SBAR? I'm going to go ahead and put together probably like 10 of these. Little things where you guys need to just come up with SBARs and practice them. And then a class in the near future, in here, we will just randomly call out people. And they will go ahead and present their SBAR for case 1 or case 2 or case 3, whatever it is. Yes, ma'am?
Is it still going to be due at the same date as the original video presentation?
At the latest, if not sooner. You're still doing SOAP notes. Okay. All right. Do I have any questions from the distance sites? If not, I'll spend just a couple minutes explaining lab next week and SOAP notes, and then we'll get out of here. Questions?
No questions.
Beautiful. I love that. That means you guys aren't listening or I'm doing a good job. I'll take either one. Okay. So, next week is a case lab again. Okay? Kind of just like what we did last week. Okay? It's on acute coronary syndromes. The topic you should be very familiar with. Okay? Since you just had a test on it less than an hour ago. Okay? It's the same type thing we just did, except for now, you're going to be doing on your own kind of what we did at the end of lab when we had the group discussion. We said, okay, well now what's your assessment? How would you treat it, right? You're going to complete that whole SOAP note. This is how it works. You're all at a table together. I know you have your own tables, okay? And I know some of your information is going to be the same, okay? However, where it should differ is when you start to come up with your assessment or your plan and your education, okay? I don't mind if you work together coming up with what is the problem list, what is the whatever else, okay? We'll be there to help you at your tables. But then when it comes time to writing out how you want to treat it and what your education should be, that's where you need to break off and be individuals, okay? They will be looked at, okay? I'm not going to look at 250 of them, I won't lie to you, but we will be looking at quite a few of them, and if we see similar things, it's amazing how you guys get caught cheating. Or I shouldn't say cheating, copying and pasting, because I remember 2 years ago I was just reading and they misspelled a word. And I'm reading the next one, they misspelled the same word. I'm like, that's silly. When the next one was like 4 later, you know, like, go back, yeah, oh look, same exact SOAP note. Okay? So please don't do that. This is how this SOAP note works. You all have to upload the SOAP note by Sunday or Monday, I believe it is. Depending on your lab day. If you're Tuesday, it's due by Sunday. If you're a Wednesday lab, it's due by Monday. I'm talking about next week. Your individual soap note. If you are in Tuesday lab, your soap note must be uploaded, and don't get used to this because in PCM2 it's a day later. Your soap note must be uploaded by, I believe it's Sunday night. And if you're in Wednesday lab, your soap note has to be uploaded by Monday night. That happened because a bunch of Wednesday people a couple years ago, they have one more day than we had to write it. Yes, we still had way too many days to write it as it is. But, okay, so we do that day. The first soap note is your first soap note. I understand you haven't really completed one. We will be in the lab helping you, okay? The way the first soap note works is it gets graded on a scale of 0 to 100. But it's only worth 5 points. So basically, if you get 80 to 100, you get 5 points. If you get 60 to 80, you get 4 points. If you get 40 to 60, you get 3 points. You can see here, we want you guys to learn how to do the soap note, okay? It's not meant to be punitive. If you do horribly and get like 20 to 40, you're still getting 2 points. If you put your name on a piece of paper and nothing else, you don't get 1 point, you get 0. But if you get less than 20, you get 1 point still, okay? So it's not meant to be punitive. I want you guys to sit and focus on it. Now, a couple keys for your soap notes. My first soap note I've gotten from some people, you can't see me, I'm holding up basically a book. It's been that thick, okay? It shouldn't be more than 10 pages at the most, okay? Okay? I don't want a 22-page soap note, okay? When I say pages, that's not like typewritten, paragraph. That's your entire soap note where you have things in blocks and charts and whatever else, okay? But try and keep it to under 10 pages, because you'll learn why. We'll just say that. It's to be continued. You'll figure out why you really want to keep it less than 10 pages, okay? Put the information you think is important. Since it's your first soap note, err on the side of caution. Too much is better than too little, right? We'll work over the course of these 3 semesters on, you guys start with these big, huge, bloated, Brian-sized soap notes, and then we get down to nice little petite Natalia-sized soap notes, okay, as we learn to trim off all the fat, okay? Kind of like we were talking about here with the S-bar. If you notice, the S-bar is kind of like the HPI, but it's even smaller with our assessment and recommendation involved, right? So our S-bar was smaller than our whole HPI, right? So the HPI is great, but now we're trimming it down even more to just communicate, right? That's what we're going to do with your soap notes over the course of the next 3 semesters, or 2.5 semesters, or whatever's left. Okay? So, questions? Last comment. In lab next week, Dr. Cologne-Pratz, Dr. Matthew, myself will have lists. You will each be assigned a random number. You need to make sure you write that number down somewhere and remember that number. And that's all I'm going to say about that. And you'll find out why on Monday or Tuesday morning. Okay? Not next Tuesday, the Tuesday after lab morning. Okay, so next week in lab, please make sure you get your randomly assigned number from your professor. You're going to need it for the following week. Okay, next week in lab, I will have a list with all of the Fort Lauderdale students' names and a number, a randomly assigned number. Make sure you get that number from me. San Juan, Dr. Cologne-Pratz will have a list with your names and a random number. You need to make sure you get that number. Palm Beach, Dr. Matthew will have a list with random numbers. You need to make sure you get that number. Because then the following week, 2 weeks from today, you're going to need that number. It's the lottery. Whoever's number I call passes the class and go home for the rest of the semester. Okay, maybe not. Once again, this isn't being recorded, so if you believe me, shame on you. Okay, you will need that number 2 weeks from now, so please make sure next week you get that number. Who wants to go home? Everybody who didn't raise their hand can stay. I don't think anybody at the distance sites raised their hands, did they? All right, good. All right, any more questions, concerns? Have a wonderful day. Bye. See ya. Ciao, bella, ciao.